Good afternoon and welcome to the Subcommittee on Healthcare and Financial Services First Roundtable. Today's discussion will be a little different than the typical hearing. It will be more informal. We won't be keeping strict time, and I encourage my colleagues to jump in with questions throughout. The goal is to have a candid discussion. For the benefit of our wonderful witnesses, who we're also lucky to have here, under normal circumstances, when this committee gets together, we have a formal hearing and you're all sworn in and there are rules, like you can't talk for more than 5 minutes. No secret why we are not doing a formal hearing today. We like this hearing to solely be focused on the issue before you, and there is some concern that both parties are guilty of this, that they make motions in the middle of the hearing and try to bring up unrelated topics. And because I'm used to a normal hearing, I'm not thrilled that we are, I initially was not thrilled that we are not doing a normal hearing. But after thinking about it for a while, I think it's superior. It's superior because we can have an informal discussion. And if you and I want to have a back and forth for 10 minutes, we can together have a back and forth for 10 minutes, just like normal people talk. Otherwise, in a rule that drives me up a wall, whenever we call on a congressman, they are restricted to 5 minutes. And if you're in the middle of a tremendously interesting thread of thought, you can't follow through. So that's why we're doing something a little bit different. There are times in which I think partisanship just rears its head for the sake of rearing its head, because I don't see how this is a bad thing. But it is possible that I guess we have about 4 Democrats on this subcommittee. It's possible they will not show up because they don't want to participate in something that's not a hearing under the normal rules, which I quite frankly think is superior. I'd like to think if the shoe were on the other foot, I'd show up, but that's the situation we're in. It's particularly too bad because upon analysis, our mental health system in this country is horrific. Okay, we're going to be interested to see what we hear from you folks, but I do believe there are a lot of people who go to see a mental health professional and would be better off not going to one at all. And instead, we are, as a country, pushing more people into the mental health bureaucracy. And as we're going to hear today, sometimes with tremendously tragic results. My subcommittee chair is not here yet. I will be hopeful until the final gun goes off that he will show up, but we traditionally now, I give an opening statement, and I will do that. We are now going to examine a difficult but urgent issue, the state of mental health in this country, why it appears to be getting worse, I would say both growing and getting worse at the same time, whether the system designed to address it is working, and what we in Congress can do about it. Over the past 2 decades, the United States has dramatically expanded access to mental health care. I might add that when I graduated from high school, if someone said, you know, how's your mental health, that was just something nobody would ever say. It was so, now it's common. In 2002, about 27 million adults received mental health treatment. By 2024, that number had grown to 60 million. So stop and think of that for a second. In the last 24 years, you're twice as likely to go to a mental health professional. You would think that spending all this money and having that many more people work on the project, that it would result in positive outcomes. But no, the outcomes are moving in the wrong direction. Depression rates are at historic highs. Suicide rates, while they dropped during the COVID, have climbed back to their highest levels in decades. And I'll point out that's despite the fact that presumably physical health care has improved, so it's harder to kill yourself, but it still goes up. As you can see from the chart behind me, do we have the chart behind me? Here we have, on the blue line, you can see that the amount of people receiving mental health care is going through the roof. However, the number of people who report that their mental health is good is falling like a stone. Okay, that raises a fundamental question. If we are treating more people than ever before, why are we not seeing better results? This is not just a public health concern, it's an economic concern too. You know, a study published last week found that from 2000 to 2021, the mental health and substance abuse disorders nominal spending grew from 41 billion to 139 billion. Mental health and substance use disorders accounted for 4.5% of all medical services spending in 2000 and 5.5 in 2021, which means, and you know, given how quickly medical spending is going up across the board, to have them go up even more is somewhat incredible. Real per capita mental health and substance use disorder spending grew at an average of 3.27%, which is faster than the growth rate for overall medical services of 2.21%. On the government spending side, more than 1 in 3 SSDI beneficiaries are enrolled due to mental disorders, making it one of the largest drivers of a program originally intended only for those with severe mental limitations. At the same time, many Americans are bearing these costs personally. 1 in 10 Americans have gone into debt to pay for mental care. And of course, the reason they go into debt is they think they're buying something of value. Perhaps most concerning is what we are seeing among young people. Rates of mental health diagnosis in children and adolescents have risen dramatically, along with the use of psychiatric medications, which are scary. Antidepressant prescriptions for individuals aged 12 to 25 have increased by more than 63% from 2016 to 2022. Let's run that by again. The number of people aged 12 to 25, the formative years, antidepressant prescriptions have gone up 63%. During that time, a total of more than 221 million antidepressants were prescribed and dispensed to 18 million individuals aged 12 to 25. Yet even as treatment has expanded, outcomes for youth continue to worsen. In 2021, 57% of teen girls reported persistent feelings of sadness or hopelessness, up from 36% a decade earlier. I mean, the point is we have more professionals in this, we're throwing money at it, and young girls are wildly more unhappy than they were just a few years ago. We're intervening more, medicating more, spending more, yet many of the people we are trying to help are not getting better. There's something in this system that is not working as intended. Let me be clear about what today's conversation is not. This is not an argument against mental health care, well, maybe a little, nor is it an attempt to stigmatize those getting help. When a system produces outcomes like these, despite significant investment, we have a responsibility to ask questions. Are we wasting money, or are we spending more money and even making things worse? Recent efforts, including the Trump administration's Make America Healthy Again Commission, focus on over-medicalization in its direction to evaluate pediatric prescribing patterns, suggest that some of these questions are beginning to be taken seriously. Our constituents know something is wrong. They're living it, they're watching their kids struggle, taking on debt for care, and searching for answers when systems fall short. They deserve a system that works, and they deserve accountability when it does not. That is what today's roundtable is about. I want to thank our witnesses for being here. I look forward to a great discussion. And with that, I'm pleased to introduce our guests, left to right. Dr. David Hyman. Dr. Hyman is an adjunct scholar at the Cato Institute and professor of health law and policy at the Georgetown, apparently, Law School. Next, we have Sally Sattel. Dr. Sattel is a senior fellow at AEI. We love AEI. A practicing psychiatrist and lecturer at the Yale University School of Medicine. And we have Laura Delano. Ms. Delano is a founder of the Inner Compass Initiative and is a leading voice in the international movement of people who've left behind the over-medicalized and professionalized mental health industry to build something different. With that, I'm supposed to call on Mr. Democrat Krishnamurthy, who's a bright guy, and we miss him, to speak, but it looks like he's not going to speak. Okay, now what we'll do is we'll give you an opportunity to each give your beginning statements, okay? Dr. Hyman, why don't we call you first?
Thank you, Mr. Chairman, and thank you to the committee for inviting me to speak. I'm going to focus my remarks on three distinct issues. First is, what do we know about spending on mental health, both overall and time trends, and substance use disorders? Second, on what do we know about fraud, waste, and abuse in these sectors of the healthcare economy? And then finally, what do we know, or what should we know about the value of those services in order to make decisions about strategies for addressing the sorts of problems that you've described already? In terms of overall spending, Mr. Chairman, you've already referenced the article I was going to start with, which appeared last week in Health Affairs, a peer-reviewed health policy journal, and took a sort of longitudinal perspective on time trends in healthcare spending on mental health and substance use disorders. Although it's not noted in the article, about 90 million adults in 2024 had either a mental illness or a substance use disorder. Of these, approximately 15 million have what is conventionally described as a serious mental illness. So there's obviously a very large delta between the total number of people and the people that we think of as having a serious problem. It's important to keep that spread in mind in thinking about policy in this area. There's also been a lot of interest and focus on various subpopulations, veterans, young adults, racial and ethnic minorities, and on access to care for each of those. Those are all important issues, and happy to talk about them in the Q&A, but I'm going to focus instead on the topics I mentioned previously. So, Mr. Chairman, as you noted, we spend about 5% of our total healthcare budget on mental illness and substance use disorder, according to the Health Affairs article that was referenced. Importantly, the rate of growth in that spending over the 20-some years that they studied was 50% higher for mental health and substance use disorders than for what we can think of as the rest of the healthcare spectrum. And I think it's not a surprise to people in the room that spending on healthcare goes up every year, but it's important to note that it's going up faster for mental health than for the rest of the system. And they usefully disaggregated that and determined that a significant chunk of that is simply because they're treating more people, as opposed to higher cost of unit service for the people that are receiving care. By comparison, most of the increase in the regular healthcare budget was an increase in intensity, cost per treated person, rather than a rise in the number of people being treated. So I think it's important to recognize there are somewhat different things going on in different parts of the healthcare system that are driving these increased spending. If you look at where the money comes from, it will not surprise you that the federal government, through the Medicaid and to a lesser extent Medicare program, is footing a significant chunk of the bill. Private payers are responsible for about 35% of healthcare spending, out-of-pocket payments about 8%. Medicaid alone is reportedly responsible for a quarter of total mental health and substance use disorder spending in the United States. And there's also obviously community mental health services block grants that are a part of that, but they are not the entirety of it. And we can talk in the Q&A about who's actually providing the services and their level of knowledge and sophistication and so on. I want to transition to talking about everybody's favorite topic in Washington, which is fraud, waste, and abuse. There is no constituency in favor of fraud, waste, and abuse, and so it's actually a useful target. But the reality is, if you look at the healthcare system, to quote a co-authored piece I did in City Journal 2 months ago, it's not just Minnesota. Fraud is everywhere. And in a book that the Cato Institute published some years ago, we highlight the ways in which, no matter where you look, you find fraud, waste, and abuse in healthcare, misaligned incentives and misuses in the way we use insurance, driving, all sorts of problems, not just excessive spending, but also bad quality care and bad outcomes for patients. So what about mental health and substance use disorder? In Overcharge, the book that the Cato Institute published, we highlight mental health as a, quote, fraud-laced industry. There's no shortage of recent examples, cases brought in the past year in Arizona, the District of Columbia, Maryland, North Carolina, and Texas, to pick just a few. Every year, the Department of Justice announces that it's brought a record number of cases and has recovered a record amount of money from fraudsters. These problems are not new. In 2014, the former Inspector General of the U.S. Department of Health and Human Services wrote that fraud, waste, and abuse in mental health is, quote, a special enforcement problem that stretches back decades. Many healthcare fraud investigators believe mental health caregivers, such as psychiatrists and psychologists, have the worst fraud record of all medical specialties. The list of mental health and substance use disorder scams that he catalogs in 2014 is long and indicative of the creativity of fraudsters in extracting funds from all of us, including altering or falsifying records, billing for services not actually performed, falsifying patient charts, fabricating patient files, paying kickbacks to recruiters. That's just the first 5 or so of a list of 15. There are earlier similar complaints about psychologists. There was, in 1998, HCFA, the predecessor to CMS, announced a crackdown on community mental health centers and terminated 80 of them from the Medicare partial hospitalization program. Plus, they had a 10-point program to address fraud, waste, and abuse. Evidence of this surfaced during the Clinton administration as a result of what was known as Operation Restore Trust, a 1994 or 5 crackdown on home health care, nursing homes, and durable medical equipment that also revealed evidence of serious problems in mental health. There are earlier articles as well that sort of highlight the fact that if you look at providers that have been excluded from the Medicare and Medicaid programs, psychiatrists punch well above their weight in terms of their likelihood of being excluded from the program for engaging in a variety of these frauds. Now, as this history reflects, there just isn't that much new under the sun when it comes to healthcare fraud, waste, and abuse, other than adaptive responses to changes in these programs and the way we've chosen to pay for healthcare services. So what lessons should we draw about fraud, waste, and abuse? First of all, we've spent a huge amount of time and money bringing cases, and we've had relatively little impact on the amount of money that's going out the door to fraud, waste, and abuse, often involving the same grifts and the same grifters, sometimes while they're in jail for previous frauds. We are significantly under-deterring this problem. We're slow to detect fraud, waste, and abuse, and even slower to impose sanctions, let alone recover the funds that were improperly paid out. And this record spans administrations. It spans degrees of interest in the problem. If we want to fix these problems, more aggressive prosecutions or working harder to recoup the funds is not going to do it. We need to change the way these systems are structured to make them less appealing targets. And I've got a list of strategies I'm happy to share with the committee that basically reduces the likely benefits for engaging in this misconduct. We need front-end changes rather than after the fact, what's known as pay and chase in the business. Now, fraud, waste, and abuse is the low-hanging fruit for improving the performance of these programs, not limited to mental health and substance use disorder. There are problems everywhere you look in healthcare, and plenty of recent examples, not just in Minnesota and California, but in states across the land. We need to take steps to do that. But even if we do that, and even if we save all that money, that will not solve the problems that you ended with, which are serious concerns about the value of the services that are being provided and deciding where and how we should be spending money on mental health relative to how we're doing it currently. The problem is figures about how much we're spending don't tell us much of anything about the value. And the way in which we pay for these services, which are almost always based on inputs rather than on measurable outputs, compounds the problem, because the vendors, suppliers, providers, physicians, however you want to label the people, are basically responding to the incentives that we've created by setting up these programs. When we pay for services, we get services. We don't necessarily get better mental health. And so you need to think and think hard about how you would go about changing these programs to create better incentives for the people providing these services. Unfortunately, like the rest of our healthcare system, it's really hard to get answers to very basic questions about, is an additional dollar spent on this type of mental health the best way to improve people's mental health or people's willingness to work or whatever other measure you choose to use? In normal markets, we depend on supplier innovation and the disaggregated purchasing power of consumers to generate bottom-up answers to these questions. In healthcare, in contrast, we have complex regulations, restrictions on entry, opaque pricing, third-party payment, all of which make it difficult, if not impossible, to evaluate the efficiency and effectiveness of current spending, even if we take fraud, waste, and abuse out of the picture. Thank you for your attention.
Thank you. Thank you very much.
Just now. Thank you. So thank you, Mr. Chairman, for this invitation and for your interest in my thoughts on the paradox that you presented earlier, which is that mental health is worsening as we spend more money on it. So I'm going to speak mainly as a clinician here. I'm the medical director of a methadone clinic, but we see basically a lot of people with psychiatric say they have psychiatric diagnoses and they have troubled lives. So it's not just substance abuse. So in my my view, I think we can approach this issue by considering, two basic realities. The first is that clinicians are, in fact, overdiagnosing too many people who, as I mentioned, are certainly struggling in their lives, but they do not have a psychiatric condition. However, that doesn't necessarily stop them from consuming treatment and disability entitlements. The second reality is that at the same time, some psychiatric conditions really are increasing. So this is a very broad topic, and certainly I'm not going to cover everything in 5-10 minutes, but I'll just begin by briefly confirming what you already know, what so many already know or I think suspect, which is that two of the most common conditions of children, autism spectrum disorder and attention deficit and hyperactivity disorder, are markedly overdiagnosed. And I feel like I should keep saying, injecting this all the time. These are real conditions, so I'm not questioning the validity of these problems, and they've caused a lot of heartache for the kids who suffer and the parents and everyone, but they are also significantly overdiagnosed. So here's some a powerful fact. In 2023, the CDC published these data, that in that year, 1 out of every 36 children had autism, and I'm using autism interchangeably now with ASD, autism spectrum disorder. So that was 1 out of every 36 children in 2023. 2 years, even just 2 years before that, it was 1 in 44, so obviously fewer. In 2006, it was 1 in 110 children. So again, in 2023, 1 out of 36, and in 2006, it was 1 out of 110. So that is, to me, a very striking illustration of the degree to which we are identifying this more often. And over the past 2 decades, the definition has broadened in the DSM-3, DSM now 5, the Diagnostic and Statistical Manual, and that means also that more children qualify for these definitions or these diagnoses than previously. So that's one issue. And it's related also to the situation with attention deficit, ADHD, where roughly 1 in 10 youth are diagnosed with that. Again, the question is why? That's a lot, and it's more than in the past, significantly more. ADHD used to be a very narrow and very serious condition, and it still is for the children who meet that strict criteria, but it takes a long time to do an in-depth evaluation of a child. I mean, more than one visit, several hours in one visit, and these are not reliably conducted. The diagnoses, again, have also loosened within DSM. We have subtypes, so there are various kinds of ADHD types you can be, and it's now defined on a spectrum, so of course that broadens the net. And what complicates this picture further is the rush to medicate before trying behavioral treatments. Now, behavioral treatments are time-consuming. They certainly don't have to be performed by a psychiatrist. But to go straight to a medication without what's usually considered, the minimum amount of time on just behavioral therapy alone, and there is quite a good behavioral therapy for autism-like conditions. It's called applied behavioral analysis. You have to do that ideally for several months, and then maybe if you have to turn to medication, then do. And I've seen the medication be very helpful, but we want to have a higher threshold for turning to drugs. I'm going to move on to adults now and mention disability. As Dr. Hyman said, mental health represents about 1/3 of all health conditions under SSDI and about 60% of all conditions under Supplemental Security Income, SSI. There's no question at all that there are people with severe psychiatric conditions who cannot participate in the workplace, and thank goodness there is something for them. That's the 15 million you mentioned with severe mental illness. These are usually chronic psychotic illnesses like schizophrenia or bipolar. But a sizable percentage of patients that, or I should say individuals that get SSI, and I know this because they're in my clinic all the time, really do not meet criteria for a diagnosis. And even when they do meet that criteria, that doesn't necessarily mean that they cannot work. I'm talking about conditions like depression, PTSD, anxiety. Most people who are diagnosed with these and sincerely have them, will recover or at least get to the point where they can resume work. But that's not happening often enough. We see that evaluators, and I know these folks, they often assume wrongly that a disability is permanent, so that these conditions will forever keep people out of the workplace. And the requirement of reassessing recipients after 3 to 7 years on Medicaid is not happening. I've never met a patient who's been reevaluated. I'm not saying it's not happening anywhere. I'm just saying it's not happening to the extent that I've seen much of it. I've seen people who get SSI for depression, and I'm going to concede that they may have had a crippling depression at one point, and the payments really did help them, but it resolved years ago, and they were never reassessed. And to me, one of the most damaging consequences of this is that a patient has now been taken out of the workforce. And I'm not even talking about the taxes they may or may not pay as a worker. The biggest problem to me as a psychiatrist is that they're estranged now from one of the best therapies there is, which is work. Work gives you a sense of purpose. At the very least, it's a distraction from your symptoms. You don't ruminate about your condition. It's a structure for your day. It's an opportunity to socialize and cultivate friendships and be a role model to your children. And the longer a person is out of the workforce, the more their confidence erodes and their ability to work atrophies, and so they're afraid to go back, and it becomes a vicious cycle. And then, of course, there's the perverse incentive of the benefit itself, because you'll lose it if you get better. So that's a significant issue. And then I'll close by talking about actual increased pathology, which largely take the form of drug-induced psychosis. The first drug involved here is methamphetamine. That is really growing. Opioids, as you know, they're still a problem, and fentanyl is still killing a lot of people. But methamphetamine really is taking off, and it's been big on the in the Midwest and on the West Coast for quite a while. People who take it regularly often experience intense paranoia, delusions, and hallucinations. They can be quite aggressive. And 15 to 30% of this group in 15 to 30% of this group, those symptoms can persist for over a month. These patients require a lot of service, a lot of that is expensive and very provider intensive. Emergency room and psychiatric hospitalizations for methamphetamine-induced psychoses have increased markedly. Actually, have the data in the summary that I presented to your to the staff. And finally, I'll just end with talking about cannabis. Potent marijuana can precipitate psychoses in teens. There was a study last month in the JAMA Health Forum that reported on data from 460,000 teenagers in the Kaiser Permanente system. They were 13 to 17 years old and followed. These studies are very helpful when they follow people forward. They followed them until they were 25 years old. And teens who reported using cannabis had twice the risk of developing bipolar illness and schizophrenia. Twice the risk, that's significant. And depression went up by about a third. And the reason why this study is so important is it really had a good control, because a lot of these kind of studies could be criticized where you have a selection problem. In other words, the people who are using more cannabis are the people who are already predisposed to having these conditions. But in this particular study, they excluded any child who had any mental health condition at the outset. So they were much closer than many studies to finding a causal relationship between exposure to cannabis, which these days is much more potent than it was years ago. So to sum up, I used my time today to lay out a number of dynamics that have led to increases in mental health diagnoses. Plausibly, we're spending more money because clinicians are treating both more real conditions and also generating more invalid ones. This is by no means a complete summary. We can talk about some recommendations that I have, and also the social media dimension, which of course would have taken all the time right now. So thank you so much for your time.
Thank you, Chairman, and members of the subcommittee for inviting me to testify before you today. My name is Laura Delano. I'm the founder of Inner Compass Initiative, a nonprofit organization that helps people make informed choices about taking and safely tapering off psychiatric drugs. Nearly 1 million people have found their way to our information and resources over the past 8 years. I'm also the author of Unshrunk, a memoir of my 14-year journey through the American mental health system. I am here today not as a clinician or researcher, but as a former patient. I entered the mental health system at 13 when my parents, struggling to help their angry, despairing daughter, God bless them, took me to a psychiatrist. I was diagnosed with bipolar disorder and told I would require meds for the rest of my life. Over the years to follow, my list of diagnoses accumulated. 2 meds became 3, 4, 5. My life unraveled. I gained 70 pounds, developed chronic health issues, was constantly exhausted, and became increasingly anxious and suicidal. Eventually, I couldn't work or take care of myself. Nobody told me that the medications I'd been on for years were approved by the FDA based on clinical trials lasting, on average, 6 to 12 weeks, or that the safety and efficacy of taking multiple psychiatric drugs at once has never been properly established. Nobody told me that these drugs can cause serious physical health problems, disable sexual function, worsen emotional distress and cognition, and, in some cases, increase suicidal thoughts. Nobody told me that what I experienced whenever I missed a dose or tried to stop a med was withdrawal symptoms, not a return of an underlying condition. Instead, I was told that my worsening state meant my illness was so severe that it was now resistant to any treatment. At age 25, convinced there was no hope, I tried to kill myself. It's now been 16 years since I last took these drugs I was told I would need forever. We are told the country is facing a mental health crisis. 23.4% of American adults, 61.5 million people, have a psychiatric diagnosis, including 1 in 3 young adults. Suicide rates in adults increased 35% from 1999 to 2018, with some of the largest increases among working-age adults. From 2007 to 2021, the suicide rate among youth aged 10 to 24 increased by 62%. The suicide rate among children ages 10 to 14 more than tripled from 2007 to 2018. In 2024, 13 million adults seriously considered suicide, and 1.5 million attempted it. In 2023, nearly 50,000 Americans died by suicide, the highest number ever recorded, and about 20,000 more deaths per year than in 2000. Among adolescents in 2024, 2.6 million had serious suicidal thoughts, 1.2 million made a plan, and 700,000 attempted suicide. At the same time as all this, more Americans than ever are receiving mental health treatment. Since 2005, use of these drugs has risen dramatically. In children, SSRI use has more than doubled. Approximately 61 million adults and 4 million adolescents are now taking psychiatric medications. Nearly 70% of veterans treated at the VA are prescribed these medications. More than 1 in 3 foster children are medicated, nearly 7 times the rate of other children on Medicaid, and are far more likely to be on multiple drugs at once. The financial costs are staggering. Medicaid spending on psychiatric drugs rose more than 5-fold between 1997 and 2022, even after adjusting for inflation and population growth. In 2023 alone, Medicare and Medicaid combined spent $36.6 billion on psychiatric drugs, up from $30.9 billion in 2013, adjusted for inflation. That's $335 billion over the past decade with no measurable population-level improvement in mental health. Roughly 1/3 of disability beneficiaries are classified with mental disorders, suggesting about $48 billion per year in SSDI payments tied to those diagnoses. Estimates suggest that from 2001 to 2024, the VA spent an average of at least $8 billion each year on mental health, roughly $184 billion in total, during the same period as suicide rates among veterans aged 18 to 34 have more than doubled. My testimony to you today is that what we are calling a mental health crisis is in large part a crisis of over-medicalization, of taking complex and very real human struggles rooted in nutrition, sleep, stress, trauma, substance use, relationships, vocation, environment, economics, meaning, faith, and purpose, and reducing them to medical conditions in need of medical interventions. Recognizing this does not mean denying suffering or denying that many people experience real benefit from psychiatric drugs, especially in the short term. It means questioning the assumption that such suffering is best understood as chronic illness requiring lifelong pharmaceutical treatment. How much did my 14 years of unnecessary psychiatric treatment cost? Factor in prescriptions, therapy, ER visits, programs, hospitalizations, and lost earnings from being unable to work, and the total is easily in the millions of dollars. What if our nation's mental health crisis is, in significant part, a crisis of unintended consequences, of treatment-caused harm, misread as illness, generating more treatment, more disability, and more despair? Thank you.
Thank you very much. We have two people here, and this is the best hearing we've had all year as far as quality. Traditionally, the subcommittee chair goes first. Well, I'll ask some questions, then we'll turn it over to.
That sounds good. I don't know where to start.
Right.
I don't know what to start.
First question is for all three of you together. And by the way, I think you all are interesting. I mean, I think the mental health establishment in this country is such a total scandal. And it's not only, it's partly a scandal. We're losing probably billions of dollars unnecessarily. But even more, it's a scandal because we have so many people entering the mental health establishment thinking they're going to solve their problems. And as you just said, instead of solving their problems, in too many cases, they made their problems so much worse. We'll start out with a question for all the witnesses. The Centers for Medicare and Medicaid Services report healthcare spending totaling $5 trillion in 2023 to treat chronic and mental health conditions. Yet by nearly every objective measure, despite spending $5 trillion a year, is that right? That's what it says? Yet by nearly every objective measure, the mental health of the American population is worse today than it was 10 years ago. We keep spending more and more on mental health, yet Americans report historic highs in levels of mental health problems. What explains the disconnect? And want to take a swing at that, baby? Go ahead.
If I can clarify, I believe that $5 trillion figure is all healthcare spending, not limited
Oh, you're
to
right, you're right, you're right.
mental health or chronic illness, although chronic illness, as you know, is a very significant chunk of total healthcare spending. But that's all healthcare spending on
Yeah, but you're
everything
right,
from
you're
heart
right.
attacks and car accidents to depression, schizophrenia, and so on.
Please.
Yeah, so I mean, I teach law students, and I often start by explaining to them the first rule of holes is when you find yourself in one, you should stop digging. So more money devoted to the way in which we're paying for healthcare is not going to get you better results on that or a host of other issues that our healthcare system does not do such a great job with. I don't think the problems that we're talking about are unique to mental health, to say the least. You've talked to patients with all sorts of other medical concerns, and they will have their own set of complaints about the healthcare system, some of which are the same and some of which are different. And it goes back to, as I suggested in my original remarks, misaligned incentives, bad or inadequate information, trying to use insurance to do things that it's not well suited to, and a host of other things. But doubling down on what we're doing, which isn't working, is not going to get us anywhere better than where we are. It'll get us the same or worse results with more money and not so much to show for it.
Okay. The ACA mandated that mental health be covered in almost all health insurance plans, which include all Medicaid, ACA marketplace plans, and employer plans. Does this requirement increase the price of insurance as well as taxpayer expense to fund Medicaid?
Yes.
You think substantially? Okay. And that's always a problem we have. Right now, they're screaming we got to put more money in it, but obviously it's more expensive. Worse, more than 1 in 3 Social Security disability insurance beneficiaries are enrolled due to mental disorders. While these benefits are critical to a lot of the individuals, are these programs being abused? These are all supposed to, one more for Mr. Hyman, Dr. Hyman.
I thought we were going to share the wealth, Mr. Chairman.
Don't worry, next we're going to go to Dr. Sotell.
I think there's considerable evidence that the programs have a variety of problems with fraud, waste, and abuse. How much of it is driven by patient strategic behavior, by lawyers seeking to qualify people for disability? I mean, there are late-night television commercials from plenty of lawyers that say we will help you qualify for disability and you don't pay anything if we don't succeed, by clinicians of a variety of sorts who benefit from treating more patients and doing more things to them. I mean, we can continue along a list of people to blame if you like. I'm not looking at Dr. Sotell. Although I was looking at her earlier, hoping she would answer the question, so I wouldn't have to. Look, as with anything else, there are some people who are desperately in need of these services and may well have significant difficulty accessing them, particularly in the absence of some kind of insurance or socialization.
And we're assuming that they'd be helped.
If not, the medical profession has a lot more to answer for than in my list of particulars.
Okay.
Right?
One other comment before we go to Dr. Sotell. You write for the City Journal? You've written for the City Journal?
Yeah, I had a piece in the City Journal.
Congratulations. It's a secret gem for anybody listening back home. If you don't have enough to read and you want to subscribe to a magazine, the City Journal would be a good place to start. Congratulations. Okay, we're going to go to Ms. Delano. At 13, you were told you had bipolar disorder and would need psychiatric medication for the rest of your life. At age 13, these people are nuts. Based on your experience and your work with patients through the Inner Compass Initiative, how often do patients, especially young people, receive clear, informed explanations about what their diagnosis means and the evidence behind the prescribed medications and potential long-term risks?
From what I've seen, never.
Okay. That's what we like, short answers. Kind of shocking, isn't it? You're down, and it's difficult to get off these meds too, isn't it?
It's incredibly difficult. And we have a system set up that makes it incredibly easy to start these drugs that were really only ever studied for short-term use, yet most people stay on them long-term for years and have zero safe off-ramps. And every time they try to get off because there are no safe tapering guidelines available currently anywhere in any trusted public or private authority, people generally come off too fast and feel horrible and don't realize that they're actually in withdrawal and think they're having a relapse of their illness, which is proof that they need their medications. And I would wager that a significant percentage of these long-term medication users are actually people who don't even necessarily want to be on these medications long-term, but every time they try to stop, they feel horrible, and so they see no other option. And so I do think one of the most important priorities from a policy reform perspective is updating labels, providing safe tapering guidelines to clinicians, patients, and families, educating the public about the fact that these drugs can cause physical dependence, not addiction. It's different than addiction. It's not like you're craving your next fix of Zoloft, but your body can become physically dependent on these drugs such that getting off them may need to take you many months or even years for some people of very slow tapering. Right now, it is only lay people like me who know, who have this information here in the US. There are tapering guidelines in the UK and Australia that have been adopted by a growing number of health authorities over there, but we don't have any yet here, and we desperately need them for the 65 million Americans on these meds with no safe off-ramps.
So a lot of these people, they were put on a path to lifelong dependency at age 14.
Yes, and in part because you're told this is an incurable illness. You'll have this for the rest of your life. It's manageable with medications, but you will never not have it. And that's the story that many, many people are being told about these conditions, which is simply not true. It certainly wasn't true in my case, but when you're told that by a doctor you trust, you just assume, okay, this is the rest of my life.
Well, it's the same breed who has been doing sex change or sex reassignment surgeries to 14-year-olds, I suppose. Crazy, crazy people. You founded the Intercompass Initiative in 2018. Age 14, you're put down a lifetime path and not explained that it may be a lifetime. And you were just lucky enough, because you're a bright enough person, that you're probably one of the few people who fought your way out from under this, right?
It took 13 years to realize I needed to get out, though. And I only really made it out because I had a family who could provide for me. You know, it took a lot of resources to get myself off of the 5 medications that I was on at the end. And a lot of people don't have the resources that I had.
You could easily wound up on SSDI and
Oh, totally. I would have lived in group
just a
home.
basket case for life because of this ridiculous profession. Okay, you founded the Intercompass Initiative in 2018. We're just saving up the questions there for Ms. Sattel. So, you founded the Intercompass Initiative in 2018 specifically because when you went through psychiatric drug withdrawal yourself, you discovered that almost no medically supervised guidance existed for how to do it safely. Your organization has since worked with thousands of people going through the process. As of 2025, your organization notes that formal scientific studies on the safest methods for withdrawing from psychiatric drugs remain virtually non-existent. How is it possible that drugs being prescribed to millions of Americans, including children, have no established evidence-based protocols for discontinuation?
It's a good question, and I wish I knew the answer. I think a part of it is just a lack of proper surveillance of, once these drugs are out on the market, my sense is that the regulatory mechanisms that could require ongoing surveillance and monitoring are hard to pin down. And so, you're just kind of out there in your life on these meds 1 year, 2 year, 5 years, 10 years, and who has oversight over that? Who's touching base, creating stop points to check in and say, how are you feeling now? Is it time to maybe revisit this?
Were you the one who told me, and we've talked to people obviously in preparation for this hearing, that if you have, and then I got to go to Mr. Gosar soon too, because he's so much better than me. You get these little capsules with the little beads in them, and in order to get yourself out from under this, you start by taking a whole capsule, then a capsule has 2 beads, then a capsule has 4 beads. Is that something people have to go through to get out from under these things?
All the time. And because it sounds so unfathomable that a capsule with 276 tiny little beads in it might require chipping away, removing bit by bit over not just months, but years, people just don't believe that this is necessary. But for many, many people, their bodies have been so profoundly altered by these drugs that it takes this teeny tiny gradual reduction over years to enable their bodies to handle the change.
Yeah, I don't know whether to blame the drug companies or the psychiatric industry for this.
This is the next opiate crisis, and I think it's bigger.
Good. You won't leave if I let you ask questions now.
What?
You won't.
Well, I'd love to ask some questions.
Why don't you ask a couple questions, but don't leave, because then I'm going to ask my question.
So your knowledge, am I on?
All the way from Arizona.
Yeah.
All he goes there.
Well, I was a dentist, and so I got to see a lot of this. And so, first of all, I would say to the Dr. Hyman, thank you very much for Cato doing I'm the only person to have killed a national emergency, and you guys followed up on it very, very well. So thank you very much. I see the frustration in all three of you. And the system isn't working. Like you said, Dr. Hyman, it's not working, it hasn't worked, and both sides can take the punishment for this. Because we're not dealing with just mass people, they're individuals too. So I want to talk about something that you said, Lauren, and hinted at by you, Doctor, was we are what we eat. So I'm a glutard, I'm a celiac sprue person. So I found out very innocuously, and that is my sister had her second child, and their first child would go in these dyskinesias for no apparent reason. We're just beyond total dyskinesia. Well, my sister, who was a physician, had just come back from an ectopic disease for him, and she thought, well, he sounds like Charlie's got celiac sprue. Well, sure enough, they kicked the kid off of gluten. Kid's a straight A student. He's calm, there's no dyskinesias, nothing. Okay? So I start seeing it. I see it in my two girls. I've had two girls, and they got the same kind of problems. They can't touch gluten. And they're dysfunctional, they don't feel good. I think there's a lot to do with it. So I run across this gentleman. He's a physician, and he believes that we ought to be inventorying as a baseline all foods on an alkalinity or an acidity basis. And bacteria don't grow in alkaline situations. They don't do very well. So what you're trying to do is you're trying to maximize putting these together so that you're getting as close to neutral or slightly alkaline as possible. He's illuminated everything from spinach leaves to all this. And I think that there's something there that can happen. But we got to be able to do something with this. So the first thing is that we have to separate healthcare and insurance. That has to happen. Because we have to build a healthcare model that's healthcare based. And then we can see what insurance can do to help us out with this. And we missed a boat. We could have been far away onto something. And that is that in January or in December, we should have had all the insurers in here under oversight. We're a nimble committee, asking them, what did you spend your money on during COVID? Okay? And then you'd have the Medishares over here, and you say, listen, how much are you getting compensated for your work? $179,000? Whoa. And how much do you save per average person? Very different than the Humanities Kaiser Permanentes. Okay? So I think you have to start there first. And once you get that, then how do we empower people? Okay? There's cruxes with family that are called psychological aspects. There's food. There's environment. There's lots of different things that affect us. So would you agree with me, and I'm just going to go down the line, that that's a good way to start? Lauren?
Yes.
Well, maybe yes, with caveats, because
Okay.
honestly, I mean, I'm not a nutritionist, but I think these things are really quite complicated. If I might, you don't want a one-word answer, right? 'Cause I wanna-
No.
Okay, good.
I want this dialogue.
Okay, well, great, because the question that we kind of started with, but relates to yours, is, what is happening now? And it's a sociologic question, really. And I think Laura, towards the end of her comments, really explained, it was an eloquent articulation of all the existential crises that people are dealing with. And I think that as a culture, we tend to medicalize, often medicalize distress. Not always, certainly not always, and I wish we'd make more of a distinction between mental health and. Just a second.
Can I ask you one quick question anyway at the door? You don't have to, I know you got a plane to miss, I'm sorry to jump in here. The Make America Healthy Again Commission has directed the Department of Health and Human Services to evaluate prescription patterns for psychiatric drugs in children. In your opinion, should that evaluation also include an investigation of what happens to children when they begin to when they try to stop taking these medications?
Definitely. Definitely. It's urgent that we better understand what is happening in people's brains and bodies from using these medications long-term and from trying to get off them.
Okay, thank you for coming here.
Thank
I'm
you.
sorry we had a problem on the floor and things went overboard, so we're just going to have to rely on these two people to carry the ball. But you've been very interesting, and I'm sure I'm going to talk to you on the phone again and again and again.
Anytime, and thank you so much for the honor and privilege of being here.
Thank you. Now we're going to have Mr. Are you a Dr. Gosar?
Once was, I guess.
I'll say Dr. Gosar.
Yeah.
Oh,
No, and so I think at this point in time, I just really think that we got to get to base levels, whatever the base levels are, because everybody's an individual.
Right.
And, we were talking earlier, my sister's a physician. She was a psychiatrist. She was 3 months away from getting her degree, and she walked away. She walked away for some really serious issues. But then she went to a place called Wyoming. It has no psychiatrist, okay? And so what they did is something creative. They used people from Billings, Salt Lake, Denver, and Scottsbluff. And what they did is they did their rounds, and they took primary care physicians who had a predisposition into looking at mental health, and they made them do the rounds with them, and then they adjudicated that work to them while they were off in their other practices. Works very, very well. Mm-hmm. I was a dentist, and what we did is we did a lot of telehealth. And we were probably the first ones to do it, by the way. And there's something with that. And I go back to my veterans. In Arizona, where I'm from, we have a lot of veterans. And I think we start with our veterans. If we give them the care and we can see the results, I think we benefit greatly for it. We have to be very astute and very honest with the public, though. When somebody says that cannabis is for a veteran, say, no. That's not going to work. So we also have to have that way to bring them into the fold. Would you agree that, Dr. Hyman, that we got to start at a full baseline and start over?
So you're not going to like the answer. The history of American social policy is we basically never start from scratch. We pretty much always build on what we've done before with all of the imperfections. The sort of exceptions are wars and natural disasters, which change the facts on the ground in a way that makes it possible to do very dramatic things. So the single largest school reforms were in New Orleans following Hurricane Katrina, which destroyed the existing infrastructure and dramatically changed the possibilities for the school board and for the children of New Orleans. So no matter how much we would like to think we can just sort of wad up everything we've done. There are existing interest groups, there are settled expectations, there are existing institutions. It's going to be very hard to do that. I think,
Even with our debt?
I'm sorry?
Even with our debt?
Even with our debt. I mean, and when, what's the saying goes, how did you go bankrupt? Well, first is slower than you can believe, and then faster than you can possibly imagine. I think when the reckoning comes due on the debt, it's going to be the equivalent of the natural disaster or war. And then that's the circumstances when starting from scratch suddenly starts to look feasible. I mean, it's no different than filing for bankruptcy, right? The rules suddenly change.
But couldn't you get on a lower level where you're starting, with new physicians coming out and people that are interested in trying to get this to move forward? Don't you think that is a way to go and empower patients? Like, for example, the model that the president put forward is health savings account, but let it roll over. Why should the insurance get that? And then put it in front of them. Bring them in and then say, listen, why can't this work? Empower the patient. And then you're going to start to see that natural environment of the best management practices, best practitioners really come to the forefront. Can't that work?
That's very different than what you started with, right? Which is why I pushed back on that one. I think bottom-up strategies are happening already. That was part of the argument that Professor Charles Silver and I made in Overcharged, that the dysfunctions of our current system are revealing people willing to do very different things to avoid health insurance and pay out of pocket, to offer transparent pricing, and try and cut insurance out of the market entirely, to emphasize nutrition and exercise as opposed to, dealing with type 2 diabetes and obesity after the fact. That, I think, is happening already. We're going to see more of it, in part because, our debt makes it hard to paper over the existing problems with these programs indefinitely.
Would you both say that you start with dividing up insurance and healthcare?
So I apologize for asking you to clarify your question, Representative Gosar, but what do you
Would you
mean?
agree that in order to start somewhere where we're helping people, we've got to separate insurance from healthcare? You have to define what you're going to do with healthcare and then see what the insurance companies can help you with?
So insurance is a way of paying for things, right? Ideally, things
And not
that
paying for
are
things.
well, that's a separate question we can talk about, and prior authorization is its own separate kettle of fish. But insurance is designed to deal with things that are exceptionally low probability but catastrophic consequences. That does not describe most of healthcare, right? Much of healthcare is predictable. Certainly at a population level, and much, but certainly not all of it, is much lower stakes. So well-baby care and much of chronic illness treatment simply doesn't match the insurance model. So I've argued elsewhere, and I agree with you, that we shouldn't be using insurance for a lot of these things. We shouldn't expect it to fix these problems. We'll end up paying for having insurance included, and there'll be higher prices because insurance is included. That doesn't mean it doesn't have any role. It just means we're using it in ways that it's not well suited to.
Right. But would you say the same thing, Doc?
Well, I would reflect on one of the models that that you mentioned about doctors and other practitioners in Utah, with your sister was involved in, and it would be a combination of a mental health practitioner and also someone, someone who's an internist, because patients they may have psychological problems / mental problems, and actually, as I mentioned before, I think we have to be more definitive about trying to draw a distinction between what's mental health and mental illness. The mental illness are these severe conditions that you mentioned earlier, this chronic psychotic illnesses. They're not being taken care of. We're not spending enough on them. But anyway, back to the, and one of the biggest problems in severe mental illness is that there's not enough of the integration that you just alluded to, of these two kinds of practitioners with different expertise. And in fact, when it comes to people, again, with severe mental illness, that integration should involve social workers and rehabilitation experts, vocational, this kind of thing. So that's not happening enough, at all. With going back to mental health, I was alluding to earlier the fact that I think we now are pretty entrenched in a cultural script that tends to medicalize, frankly, existential problems. That's kind of our language so often. If you feel you're not, I can't tell you how many people I see who tell me they're depressed, once got a diagnosis they're depressed, but their diagnosis is really demoralization. And it can even lead you to kill yourself, to be honest, especially if you have a moment of impulse, you're drinking and you're feeling there's no hope for the future. You don't need a diagnosis of depression to do something awful. But do we need medications for that? Do we need psychiatrists to make that distinction for the person that, no, your life is difficult. You're actually having a rational response to a difficult life. And that's what I mentioned before about this often being a sociologic problem. And that a lot of times that's why people aren't responding, because their problem isn't with their brain, it's with their mind.
Right.
And with the context in which they live. These are really difficult questions and problems. But, some things we can do are, again, that kind of integration where we can try to be more holistic in helping to take care of people by having folks with this expertise. Another thing is, you mentioned there's no psychiatrist in, was it Wyoming or Utah? I don't know, that may be true, but I know there's only one psychiatrist, or I should say differently, half of all counties in this country don't even have a psychiatrist at all. And for the severely ill, that is so important. Another issue is that I have to say about 50% of my colleagues do not take any insurance. Forget Medicaid. They don't even take private insurance.
Right.
Now that's sort of almost a moral issue that we have to grapple with, because when you go to see a cardiologist, they don't say, well, I don't like your angina, it's a little too unstable, so I'm not going to take you. That's something we should debate. But if we did pay, I have to say, this would cost a little more money. If we did pay psychiatrists more, I think they would do more public sector work. Right. So there are these some things you can work within the system, but a lot of this is cultural.
Well, and one of the biggest sectors that we have in our society is veterans. PTSD.
Oh, yes.
And what we see with them when we take them out fishing or going up, we just got this wonderful working ranch that is for the whole family. And we just got it dedicated to Gila County. And the whole family goes out to enjoy. And they work the ranch. You made the question about work. They feel like there's a benefit to it, and then the whole family is engaged in it. I think there's more of those things that we have to get done and do.
Yeah. Well, if I could say something about veterans, I worked at a VA for a number of years, and one of the biggest problems in the VA is that the disability arm of the VA is separate from the health benefits. And you can apply for disability without ever being treated, which is kind of like saying, being in a car accident and, you haven't had physical therapy, you haven't even had surgery, but they're wheeling out the wheelchair saying, this is yours for life, and here's your check, and this is it. And I was once involved in a hearing where, this was discussed. I know the veterans groups are incredibly powerful and very vocal, and they didn't like this idea, but one idea is you can't even apply for disability until you've had a really good course of treatment. And if you're in a situation where you're you're so sick you can't work, there should be, temporary disability for something like that, like a treatment scholarship. We'll get you through this period, but the direction is out. The direction is
Well, and the
re-entry
challenge
into the community.
And to challenge your disability, it's a backlog for 8 years.
Yes,
And
that
of course,
too, but-
and so the person's left hanging and they don't know what they're going to do.
Yes, and the longer you wait, the longer you get entrenched in this whole disability mindset. When, as you were saying, getting out of the system is often your best, not because we're going to hurt you, but because hopefully we're going to help you. But again, with the direction of getting back in the community, not keeping you as a patient forever and not on a disability, which, as I know I mentioned before, but really does remove people from probably one of what I think is the most important kind of enterprise for a person to be productive. And you can be productive on a ranch. You can be, productive in a job. But that's the goal, not keeping you, as part of the system, which I know everyone means well, but I think it happens too much.
Would you like to say anything, Dr. Hyman?
Yeah, unfortunately, not everyone means well, which is why I had a whole section on fraud, waste, and abuse. And I think it's important to recognize that that's operating simultaneously with the sorts of access concerns that have already been, I think, very effectively expressed by Dr. Sattel. So in designing the system, you need to recognize there's a gradient in severity of the problems that we face, right? The severely mentally ill desperately need help and are not getting it in our current system. We've experimented with various strategies for trying to deal with them, and none of them are perfect. But what we're doing now doesn't seem to be working well for them. But that's a different scenario than the people that have been tagged with diagnoses that are not justified, shall we say, by the evidence, and are not doing them any favors. If I can actually turn back to Chairman Grothman's question for just 1 second.
Go ahead.
The question got asked, well, how is it that drugs get on the market and we're not studying what happens when you get off of them? The short answer is it's the way in which we've set up our regulatory framework. We evaluate drugs for safety and efficacy when they're launched, and we have some mechanisms for surveillance, but they tend to be significantly underpowered. And they tend to focus on drugs where there are widespread reports of problems that emerge. But there's not a mechanism for systematic reevaluation of things after they've been approved. You could change the law to require that. It would, change the portfolio of problems that the Food and Drug Administration would be handling. And you'd need to figure out how to pay staff and so on.
And isn't it sometimes that they're marketing to the public, not to the healthcare professionals? A lot of times when I was in my practice, at the end of my practice days, people come in, there's this drug, and they say it does this, and you're caught off guard.
Yeah, so direct-to-consumer advertising has become pervasive and widely hated. And not just by providers, which is how it used to be, but now by everyone who is subjected to these ads on every conceivable occasion. And I'm sure all of you can probably hum at least one of the songs that suggests that miracle cures are available. I think there have been some efforts at getting some of the companies to trim back the aggressiveness of the claims that are being made. That's a separate question from the costs and benefits of DTC, direct-to-consumer advertising in the first instance. But in fairness, that's not the scope of the focus of this hearing. Yeah. So I can talk about it till the cows come home, but you don't want to hear it.
Well, I might. You never know. So I guess my last question to you is I could go on forever too, but my question to you is, what was the question that you came prepared to ask, or to answer? What is the question, and what's the answer? So, Dr. Hyman, what was the question it wasn't asked, and you were prepared to answer?
Well, I I should put counsel who's sitting next to you under oath and ask him to recite what he asked me to address. What I decided to address was how much are we spending on mental health treatment, and what's the evidence on how much of it is fraud, waste, and abuse. And I did my best to provide answers to those along with some other questions along the way.
Thank you. Doctors?
Oh, well, I wanted to, make the points that we are overdiagnosing in, I think, significant amount. Partly that's because we do have variations in sophistication, as you alluded to, of professionals, and most psychiatric medications are not prescribed by psychiatrists. And I don't mean to be a chauvinist here to say, we are just so much better than all the others, but we do, when it comes to psychiatric medications, certainly have expertise, but most of those medications are being prescribed by primary care doctors who clearly want to help, and now physician's assistants and nurse practitioners, again, very dedicated people, but in so many counties don't even have a psychiatrist to refer their more challenging cases to, or they do, but then there's an incredibly long wait time. So anyway, so that's that's definitely a problem. So in a way, everything is true. We're overdiagnosing. We're turning conditions that are really medicalizing normal human unhappiness into diagnoses that we then prescribe medications for that probably won't work. And then there's a whole subset of people that I could tell really weren't the focus of this hearing, but that are so vulnerable and so helpless and so needy and dependent, and some of them even need to be committed. I mean, that's a whole nother issue, but revitalizing civil commitment, there's virtue in that, because this is benign paternalism, in my view, for people who are unable to, frankly, watch out, care for themselves. We frankly could, I think, repeal the IMD exclusion, so we have more beds for, so Medicaid could pay for beds for severely mentally ill people in institutions that have over 16 beds. So on the one hand, it's a strange, kind of paradox, but these things are both going on at once, that we are investing the wrong kinds of interest and care in a certain population and not enough in another, and they're all lumped under mental health when they're really mentally ill, and then we have other people with various degrees of distress that can be helped sometimes with my profession, but also should be helped in ways that are time limited and with, frankly, more quality therapy, but they're not getting it because not enough good psychiatrists can be paid enough.
So you hit something, and I'll end this. Will AI play a part, or can it play a part in the future of mental health?
Well, we can play a part to the extent that we're trying to help diagnose the problem and suggest policy recommendations. So I'll say yes.
Okay, how about you, Dr. Harmon?
I'm confident someone will figure out a way to use it, monetize it, and with some unpredictable consequences. There have already been lawsuits about problems that have resulted, and there'll be more of them.
Thank you very much. Appreciate it. Thanks for your indulgence.
Dr. Zattel, do you believe more federal spending on mental health will reverse the trends that we are seeing on increasing depression, anxiety, and suicide? Would more money solve the problem, or is it what we're doing with the money?
Well, I think it's probably largely what we're doing with that money. It's the care, the diagnoses and the treatment are, often provided in situations where, for example, when pediatricians or even child psychiatrists, when they're visited by the young patient and their parent I mean, there are incentives, and I'm sympathetic to this. They want to help, like, for example, kids can get more time on tests. I mean, these kind of things. But even more poignant is that when I mentioned this behavioral therapy, that really is effective. It's a cognitive behavioral strategy, teaches parents how to work with their young children better, helps them kind of negotiate hard tasks by breaking them down into manageable problems that they just don't intuitively think about, but this can be shown, and then the parents can do this on. That's very important stuff. And so, to the extent that that clinicians can even offload some of that clinical work, so to speak, to the parents of these young children, that would be great. But we don't have enough clinicians who do that carefully. This is labor-intensive stuff. But so I'd say I'd like to see people who can, who provide those services to be paid at probably even at a higher rate than they are, but to be able to also redirect people who come to them with life problems and say, you have every reason to be distraught, but this is not really the place to ask for medication or to be treated as if you have a psychiatric problem.
Okay. What are the potential effects, either long-term or short-term, when treatment methods, well, and a little bit of related but unrelated thing, I'll ask you this question. One of the topics that I deal with around here is the government right now has policies designed to have more and more people, not the traditional family, encourage the, two parents not to be with the kids. And we never talk about it. Here I'm having my own little hearing. We haven't talked about it so far. But in your opinion, is some of the things that people come to you guys for treatment, depression, anxiety, suicide, that sort of thing, do they go up or down with whether or not people, either they themselves or their parents, are married, or whether they are in what they call a broken family? Does that have an impact on the increase in depression, and maybe one of the reasons why I hear about mental health problems that we never heard about, or it wasn't talked about anywhere near as much anyway, when I was a child? Is that a factor?
Yeah, it's sort of well known that chaotic families, even if the parents aren't married per se, is not so much the issue as whether there's a stable home life and a predictable, caring, reliable, loving individual, and they're not witnessing, domestic violence, and someone cares about their homework. These are, at a very young age, this kind of coherence is what really manufactures, it's what's creating, a young personality, and the things that every young child needs, which are, the ability to delay gratification, have impulse control, try to solve their own problems at least, have trust in other people, soothe themselves when they're distressed, hopefully
You're
even have a
focusing on
sense
the-
of their future. And so that kind of thing all depends on a stable family, whether with two parents usually.
Right. And we could be talking about two parents. I'll also talk about the adults themselves. Do you find married couples are, or frequently unmarried couples, people been through divorce, people never married, are more likely to have problems than people who are currently married?
Well, being married tends to select for people who are, more interested in family development, have a sense of, again, a sense of a future going forward, want to maybe more involved with religious institutions, this kind of thing. So these all correlate with more, more stability and more psychological health.
Dr. Hyman, do you want to comment on that?
Just on the last part, because this is not really my field, but it's important to compare apples to apples, right? So children are not randomly assigned to families. Who gets married is not randomly assigned. Who they get married to is, thank goodness, not randomly assigned. And so, inferring causation when there's these other selection effects going on, you have to be very careful.
Yeah, and another thing we tend to do is often see things as, genetic, and they may be, obviously, they're your parents, so you inherit certain kinds of vulnerabilities and proclivities. But the other part that's so important in shaping young behavior is that you're watching these parents, you have these models in front of you, and some of them are constructive and others are very unhealthy. So, and that confounds whatever genetic contributions your parents, gave you. And there's a lot of bidirectionality in this phenomenon.
What are the potential effects, either long or short term, when treatment methods are provided in an improper manner? We heard about it so overwhelmingly from Ms. Delano, obviously. I mean, her experience was just, should really scare people into at least ever taking a middle school kid to a mental health professional.
I agree. Sometimes I had a colleague who took her son, who was just felt a little lost. He took her to a psychologist, and after the evaluation, she told my friend that not only was her son suicidal, but he should have a certain kind of brain scan. And she called me, and I said, "That is insane, do not do that." I suggested she actually report that psychologist to the, state medical board. Her son's doing fine. The issue was finding what was interesting to him and then figuring out a way for him, in addition to going to school, but have this new hobby. And some kids will be suicidal, and they don't need a brain scan, but that's a serious problem that needs to be taken care of. But I think the situation that my friend encountered, sadly, happens too often, and people don't think to report. I mean, if there's real damage, you can always have a malpractice case, but they don't think to report. And the boards kind of pay attention to this stuff. They really do look at doctors or clinicians who are creating, and then you'll get a critical mass of people making complaints about the same person.
This is actually an area I have looked at. It's actually very difficult to bring malpractice cases successfully against psychiatrists, relative to other medical specialties, but discipline cases against psychiatrists are much, much higher than for other specialties. Unfortunately, it turns out most of that appears to be for sexual exploitation of their patients, which we can only hope they're not doing to their minor patients. But nonetheless, I think part of the challenge in this area for the malpractice, it's proving damages. And the standard of care, given how variable evaluations are of the same patient, complicates using the malpractice system to go after bad quality care by psychiatrists or psychologists. And the disciplinary boards, have, shall we say, mixed incentives. They don't want bad providers out there, but they do have a "there but for the grace of God go I," unless you're dealing with the most egregious fact patterns like the sexual abuse type cases that I referenced previously.
One of the many reasons why I was interested in having this hearing is I ran into a woman in my state legislative job who had a daughter who they took to a mental health professional when she was 16 years old or something, and she was a product of a recently broken relationship, which made her sad. And in today's world, I guess they recommended her go to a mental health professional to deal with her unhappiness, and they gave her a drug. And a little while later, the drug didn't work, so they gave her another drug. And somehow between the age when she was 16 and the age when she was 24 or something, she had a shoebox full of drugs that she was taking, and they'd flip around this and that. And her siblings were often doing very well in life, but unfortunately, one of the three siblings that they took to the mental health professional was so drugged on this and that that they wondered if she was ever going to get out from under it. I should track down that woman and see what had to happen to her daughter. But obviously, the huge mistake they made was to taking her to a mental health professional. And I wondered if you had any comments on that. It's something that, from the anecdotes that I hear about, maybe not that unusual, that somebody goes to a mental health professional because they're encouraging that today, and instead they wind up drugged on one drug and another drug, and pretty soon it's a half dozen drugs, and she's just helpless, whereas before she went to the mental health professionals, you could just say she felt a little blue.
It's just bad medicine. And again, that's part of the training, is to know how to treat people who are sick and to make a distinction between people who are sick and people who are having, a reaction to difficulties in life or whatever, but there are the kinds of, that are having situations that we can treat outside of a clinical setting. I mean,
Well, the question is, you heard Ms. Delano's testimony, which was scary.
Yeah. No, I read her book. I reviewed her book. Yes.
Yeah, it's like she got wiped, the 20s in her life.
Yeah.
Got completely wiped out. And when I think of the woman who I ran into, whose daughter, for all I know, never did recover from going to a mental health professional, do you think too many people are going to mental health professionals? You're obviously rolling the dice as to whether it helps or hurts.
I think that that's a vague term, but almost like societally have given people kind of the idea that that's what you do when you're not feeling happy, is you seek out professional help. And so, yes, those people probably shouldn't be seeing a psychiatrist. And at the same time, I know I'm repeating myself a lot, but I feel like I should, because we have this whole other population of people who are so sick and they can't even get in to see a psychiatrist.
Well, we've had kind of a lengthy hearing. Have we had a lengthy hearing? You guys are wonderful. I do, as I mentioned, have serious concerns about the mental health profession. I mentioned in passing these crazy people who recommend physical surgeries for people with gender dysphoria. I mean, I think anybody, any mental health professional who goes down that path ought to be, had their...
No, but, Mr. Chairman, may I
You may.
Okay, that's where, believe it or not, that's where you do need us, and we're left out because these kids are not being given the psychiatric evaluation they need. They're being often just, they go to see a gender-affirming therapist, and then the pathway to, hormones and blockers and, surgery even, although that's a minority, but still, takes place. That whole trajectory is initiated because there was never a period of, and it has to be a long period, of several months of evaluation by, doesn't have to be a psychiatrist, but just a sophisticated adolescent professional who can try to, understand what is really the problem, because so often kids will think, I'm trans, but really it's a contagion. I know everyone knows this at this point, especially among girls. They get all wrapped up in it. It's a displacement for their other problems. It's a stand-in, and often when they come out, so to speak, as trans, they get so much feedback. It's very exciting to them. They're embraced. They're heroic on a small scale, and that's all very gratifying. But really underneath it, it's other problems, family problems. Maybe it's a genetic form of depression. People do have autonomous depressive problems where their life is great, but they just are depressed. But you need someone to sort that out and not let it be disguised as a gender problem. And that's one thing that my profession could be good at if we were referred kids like that, and they didn't just immediately go on to these more invasive kinds of treatments.
Does your profession believe under any circumstances a 14 or 15-year-old should have surgery for this sort of thing? Under any circumstances?
I honestly don't know what my profession thinks, but on this, because I haven't seen a statement. But I think most of us would be incredibly skeptical of such a move.
Somebody's doing it. I don't know what schooling they get to do it, but it's unbelievable. In any event, thank you for being here. We may do follow-up questions later on. Perhaps we had a little bit of a problem here today in that we had floor votes, and they started way later than they were supposed to start, and nothing I can do about that. And I think maybe the reasons a couple of these people didn't show up was because they had this set aside if we would have had the time when we originally thought we did. But you're very interesting, and hopefully something will come of this. Obviously, we're looking for a way to save money, but even more, these stories that Ms. Delano have, and the person that I knew whose daughter was obviously over-medicated, and just flat out the number of medications given to people because they feel blue. I'm not even give you the question. Should people be on antidepressants if they're just sad? I have a feeling that happens all the time.
It does happen a lot, I suspect, but the medication won't help, so they shouldn't be on it. We shouldn't be on a medication that's not going to at least have a high odds of providing some benefit.
Sadness and depression are two different things. We should be treating the latter, not the former, at least not with medical drugs or anything that's really plausibly medical.
I'm under the impression that they prescribe drugs pretty damn quickly. I mean, I don't know what percentage of the people are clinically depressed and what percentage of the population feels blue, but I have a feeling.
I do think, and that goes back to something I said earlier, which is that the majority of prescribers are not psychiatrists. I don't mean to imply we don't make some errors, unfortunately, but primary care, they hear this all the time. Going through a divorce, I'm really miserable. Oh, I can give you, and everyone means well, but it's just the wrong use of that medication, and it's not going to have much benefit.
I just point out, Mr. Chairman, this, again, is not unique to psychiatry. There's longstanding problems with people taking their children in with an ear infection and walking out with an antibiotic prescription, and adults showing up with a viral infection and walking out with an antibiotic prescription. And the logic, such as there it is let's close this clinical encounter by my handing you a script. You feel satisfied because I've done something for you. The insurance company will pay for it because I've done something for you, and I can get on to the next patient.
At best, it's a placebo, at best.
I have a thing that happens all the time, yeah. Whatever the motivation is, get them out the door or whatever. But I think, well, thank you for being here. I got to shake your hand, too. We can't let's just pause, shake your hand. And we'll let the other people on the hearing know you were here. Maybe they can give you some questions that we'll forward. And thank you. I mean, you're very interesting. And I think there are clear problems in your specialty, bigger problems than in other specialties, I think. Higher percentage of people who are made worse, not better anyway. Thank you for the time.